Hello everyone. This video will introduce common diagnostic respiratory lab tests. Sampling for these tests generally requires collection of some type of bodily fluid. These are the most common collection techniques. We'll use phlebotomy, urine collection, nasopharyngeal or nasal swabs, sputum samples using various techniques like BAL stands for bronchoalveolar lavage, and bronchial washing. There's some optional videos on those techniques in Brightspace, as well as pleural fluid collection and tissue biopsy. First, we'll talk about sputum samples. Sputum, first of all, is the thick thick mucousy part of what we would spit out or in our bronchial and airways. It usually contains bronchial epithelials and alveolar macrophages. So those are the things that we're looking for, hoping to get. As far as collecting this, the least invasive is what we call a spontaneous sputum sample. So this would be giving the patient directions to essentially clear their throat or try to clear their throat from as deep as possible, and then spit that out into a sterile container. While it's the least invasive and easiest, it generally has much higher risk for contamination from saliva and the bacteria in the mouth that's undesirable, and epithelials from the mouth as well. An induced sputum sample is the next step up, slightly more invasive in that we use a 3% saline nebulizer to give sort of nebulized saline to essentially provoke a cough and bring up some of that deeper sputum and mucus. It's generally safe and well tolerated. There are sample videos in Brightspace that you can watch to see how this is done. The next step up and much more invasive are these two procedures. The nasopharyngeal aspiration. Again, this is usually done by a respiratory tech or respiratory therapist. They'll actually use a flexible catheter through the nose to inject liquid saline down into the upper respiratory tract, and then they suction that back out into the same syringe and use that sample. And then finally, bronchoscopy is by far the most invasive, including the necessity of sedation, because you're introducing a larger, while flexible, there's a flexible option that's a fiber optic scope that you can see there in the black with the curved tube. And then there's the rigid bronchoscopy. And both of these procedures are generally done by a pulmonologist. This allows for direct visual inspection of the airway, at least the upper airway. And then they can introduce tools through that, such as injecting the sterile saline that they would call bronchoalveolar lavage or BAL. They could also introduce surgical tools to do direct biopsies, cautery, cryotherapy, laser cautery, or put a stent in if needed. There are potential contraindications. Of course, it's extremely expensive because of the nature of the procedure. Contraindications would be anytime that potential for complication is high. If the patient is already in severe respiratory distress, this may not be the right thing to do to introduce scopes down in their throat. Some of the common things that you'll see is, since you're introducing something down the throat, there's often a vagus nerve stimulation, so it might cause some tachycardia, bronchospasm. Since you're introducing a scope into the airway, it's taking up physical space, so it might cause hypoxemia, Hypoxia is generally pretty common during this test, and since it's a short test, generally it's usually not a significant risk unless the patient is otherwise unstable. There's always some degree of risk with sedation, also suppressing the respiratory drive. And so you just want to be careful in who you're doing this on. Of course, the patient in their struggle to breathe, even unconscious, might cough and create some aerosols that you would want to be aware of, especially in infectious diseases. Next, we'll talk about some blood tests using phlebotomy. The first of these tests that we'll look at is called the D-dimer. And D-dimers are protein fragments from when a blood clot resolves in circulation. Indications for this, the most common by far is to rule out pulmonary embolism. I would dare say almost exclusively is used for that. It can also be used to give an idea of how severe DVTs are. DIC stands for disseminated intravascular coagulation. This is a severe clotting situation. If the D-dimer is positive, the specificity is actually pretty poor because it can be generated by DVT or DIC, or even potentially, if someone fell and had some major bruising, that would even cause the D-dimer to be elevated. It has a very good sensitivity, however, especially for when you're looking for these coagulation disorders. If it's negative, low or normal, it's very unlikely that they would have a PE or DVT or DIC. So essentially that means if it's within normal limits, it's almost definitely not one of those things. Of course, with such poor specificity, you would want to use it in conjunction with other pretest probability screenings. Wells criteria, you'll hear that, and that will almost certainly be a PANTS type study. PERC rule is very similar. And then you can also use Ask Mayo Expert while you're a student and hopefully employee here at Mayo. They have a algorithm to guide you through that. Here's an example of what Wells criteria and the PERC rule look like. This is from MD Calculator website, and so you can look this up for free on the internet and then punch in the appropriate values that would help to give you a better idea of the probability of a pulmonary embolus. The next test of potential interest with respiratory infections, this kind of ebbs and flows as far as gaining favor and use, again, partially due to its specificity and sensitivity. Procalcitonin, it's produced in response to a bacterial infection and tissue injury. So it will rise in many bacterial infections. Also, as a part of the immune response to viral infections, it tends to inhibit procalcitonin. And so you might get some clues if it's very low and the patient has signs of infection and symptoms of infection, that might be viral. If it's bacterial, it will increase and often significantly higher than other forms of inflammation that can cause a procalcitonin rise. I already talked about the inhibition by viral infections. So some use in practice has been to help or attempt to help differentiate between bacterial versus viral infections. In this situation with lung diseases, pneumonia in particular. You can see here the specificity isn't isn't great with 50 to 70%. However, the sensitivity is still relatively strong, meaning that if it's low, it's likely not, more likely not a bacterial infection. Some things to watch for on this: a false elevation could also happen from severe trauma or surgery and certain chronic diseases because of the inflammatory processes associated with them. And then a false negative could happen in localized bacterial infection. So it's just a pocket in the leg or something, rather than so it doesn't cause a systemic response, creating a rise in procalcitonin. It's more commonly used if there's a lot of concern about monitoring the treatment of sepsis. So, and a patient with severe illness is hospital bound because of their sepsis, there's a quick decline in procalcitonin as the treatment is successful with antibiotics. And if you're using this, they would generally be testing this every 2 to 3 days toward resolution of the pneumonia. Next, we'll talk about serology testing or serologic testing. Serology is the scientific study of serum and other body fluids. It usually refers to the diagnostic identification of antibodies in the serum. Such antibodies are typically formed in response to an infection against other foreign proteins or one's own proteins. I highlight the word response as this indicates key limitations to this type of testing. So I believe you've covered generally in biology of disease antibodies and antigens. So just a quick review. Antigens are proteins on the surface of bacteria, viral particles, or even substances like pollen and dust mites. These will trigger an immune system response since they recognize them as foreign or harmful. Other toxins may also provoke or be and have an antigenic effect. Antibodies are technically called immunoglobulins, which are proteins secreted by B cells or plasma cells in response to one of these antigens and are capable of binding to that antigen. Depending on the bacteria or virus and class of immunoglobulin, the antibody will start to tear the antigen apart and mark it for destruction by white blood cells or block any type of harmful release of exotoxins from that organism. Because building an antibody response can take several days, serologic testing generally isn't very useful for acute decision making. Serum specimens taken very early in the disease process also may not yet have significant antibody titers or levels of antibodies in circulation, just because the immune response hasn't ramped up yet. Early antibiotic therapy will also suppress the antibody response. A positive result only indicates immunologic exposure at some point in time. So that just indicates that the antibodies, once they're created, there will always be an amount of those in circulation, sort of ready to attack the next time that same invader is introduced. So a couple of examples where we might want to use this type of test, since there aren't other great options in some cases. And so Legionella pneumophila, this is a bacterial infection that causes roughly 2 to 13% of all community-acquired pneumonia. It takes about 4 to 8 weeks to generate a significant antibody response. So referring back to that the weakness of this type of testing. The strengths is that since you're looking for the specific antibody, it can only be generated by a response to that organism. The specificity is really strong at 95%. However, a negative response has really poor sensitivity, partly because of that long time to build an antibody response. If you took a sample within the first even 3 to 4 weeks, you might not get that antibody response in the sample. And there's also possible cross reactions to other organisms with this particular test. Another one, Chlamydia pneumoniae. This is another potential cause of community-acquired pneumonia. The IgG response, it can be quicker as early as 1 week, but as late as 10 weeks. And the data that I saw, the average about 6 to 8 weeks to generate that antibody response. IgM can be a little bit better at around 3 weeks, is commonly available and able to be detected in the serology test. Positive result again here is highly specific. Here there's a little bit less chance of cross reaction. It's more the sensitivity issues is more about the timing of the test in this case, so the sensitivity can be pretty good. However, this is apparently technically a very difficult test and requires someone that's highly skilled in doing this test correctly to get the best results. Another condition you would use this for is Mycoplasma pneumoniae. A little bit more common cause of community-acquired pneumonia, 20 to 23%. This has a little bit faster reaction by our system. Generally, IgM, IgG can be found within 1 to 4 weeks. So again, a pretty strong specificity and moderately good sensitivity. And then famously, COVID-19 in the recent past, there is an antibody test for that. This test really is used to determine only if you have previously been infected with COVID-19. So the use case for this would be to confirm the COVID-19 diagnosis if persistent symptoms or late developing complications. So this would not be the test to use if someone came to you sick with upper respiratory infection symptoms. Because if the person had had COVID in the past, those antibodies would still be in circulation, so you wouldn't be able to determine from this test alone if their current symptoms were being driven by COVID-19 or something else. This test also does not confirm vaccine-induced antibodies. There's 2 different antibody tests from Roche and Abbott. And you can see the differences there in the sensitivity and specificity. In both, the specificity is excellent. So you can be pretty sure that if it's positive, they have had COVID at some point in the past. This one is always interesting to discuss when we're talking about respiratory testing. The urine antigen testing is something that's relatively new in comparison to a lot of the tests we're talking about. Approvals to use this came in the 1990s and early 2000s. Again, this is testing for specific antigens or that invader cell, their specific tests. They use this by capitalizing on the concentration of shed antigen from the variety of pathogens in the kidneys for excretion to the urine. So a urinary antigen testing can be used to obtain rapid test results related to respiratory infection, as most of these, of course, it depends on lab access, but you can get the results of these tests usually in 20 to 60 minutes, sometimes even quicker. Um, this is a big relief to patients as it can be used instead of something invasive such as bronchial alveolar lavage. Some of the common tests that are used, and these can be quite important. In this case, Streptococcus pneumoniae. This is the most common cause of community-acquired pneumonia, so this would be very valuable. Positive test has very high specificity. You can be pretty sure that if it's positive for the Streptococcus pneumoniae antigen, that's what it is. However, interestingly, the negative, there is a negative test result. There are possible false negatives. Sensitivity is only about 65%. These are also relatively inexpensive tests in most cases. The prices are difficult to find, but what I could find in the $30 to $40 price range for a medical test is pretty cheap, and the turnaround time on this particular test can be as quick as 5 to 10 minutes. Here's another and perhaps better option for that Legionella pneumophila. There is a urine antigen test for that as well. However, it's limited to only one serogroup of this type of bacteria. This bacteria is usually related to some sort of contaminated fresh water supply and breathing it in through aspiration. Quick detection in this case, if we think back to the previous slide with the antibody test in 4 to 8 weeks, in this case the antigen is detectable in as little as 3 days after onset of symptoms. Positive result would indicate that there is a current or recent infection because the antigens are actively present, so extremely high specificity. Sensitivity can also be relatively strong. And then again, inexpensive, turnaround time same day, depending on your lab, in as little as 15 minutes. Histoplasma capsulatum is especially interesting where we live currently because this is a fungus that's endemic to the Midwest, particularly in the Mississippi and Ohio River valleys. Generally, it comes from bird and bat droppings, but as you can see on this map, the dark blue is higher incidence, and you can see there in southern, mid and southern Minnesota are the dark blue areas with that Mississippi River Valley. It's a super common exposure. Greater than 90% exposed are asymptomatic. So most of the time, most healthy people, their immune system responds to it, and they don't really get sick at all. However, that other percentage of people can get quite sick and get a histoplasma pneumonia. A positive result here again, super high specificity. In this case, has a really very strong sensitivity on negative results as well. Again, relatively inexpensive. Turnaround time is typically the same day, so quick as well. So we'll wrap up this first pre-class video with pneumonia. And so this we want, like any other condition, we want to be careful about collecting a good clinical history, physical examination. Often chest x-ray are obtained to verify. And these are usually adequate for the diagnosis of pneumonia, and antimicrobial treatment is typically based on these findings and may be cross-referenced with the community antibiogram, what's going around according to the local labs. We can usually narrow the scope with these lab tests that we'll talk about and be better antibiotic stewards with thoughtful testing, but the results must always be considered in the context of the overall clinical picture. So broadly, we'll talk about microbiologic culture testing. Cultures are commonly used. However, there are limitations and some things that cultures can do that other tests cannot. So during a bacterial culture test, a sample of cells will be taken from your blood, urine, respiratory secretions, or tissue samples. The type of sample depends on the location or type of suspected infection. For respiratory infections, typically sputum or nasopharyngeal swabs, bronchial washings may improve the quality of that culture. Tissue samples, of course, provide the most certain results, but are the most invasive and most costly. The cells in the sample will be taken to a lab and put in a special environment to grow out, typically in a petri dish. This is often used as the gold standard for identification of specific organisms, and in the case of bacterial cultures, it's used for antimicrobial susceptibility testing. So those are the key uses of cultures, again, for identifying specific organisms and to determine antimicrobial susceptibility. Results are often available within a few days, but some types of bacteria grow slowly and may take up to several weeks to get a result. So we'll talk briefly about gram stain because this is often used in conjunction with or before getting a culture, primarily because you can get quicker results, usually within depending on how backed up your lab is, it could be in a few minutes, but oftentimes in an hour or two. And the type of stain can give you an idea of at least whether it's bacteria or fungi. The color of the stain helps to determine the type of type and shape of the organism. So you can see in this image there's some purple colored cocci, the spherical or round shaped cells, as well as some pink bacilli, those rod shaped ones. And so the color and shape can help to identify or at least give a really good best guess early that can help to guide preliminary treatment, and it may also be the indication to go ahead and move forward with a culture that will take much longer to get results on. But again, the benefit is to get the specific identification and antibiotic susceptibility testing. So in this context of respiratory conditions, the test to get if you want the culture is an aerobic culture, because these are bacteria that are living in the airways and exposed to oxygen. So this is used to identify common bacterial agents in pneumonia, such as those here. I mentioned Streptococcus pneumoniae is the most common. You'll often hear people call it S. pneumoniae. Induced sputum is the most specific, as we talked about early in this video, up to 97% specific if you get a really good sample. Poor sensitivity because there's a risk with contamination with the saliva that's just in the mouth or the nose that are not causing any problems in the lower airways. So you get many false negatives. Typically, you'll want to order this test with the option, and most labs will default to this, a reflex test for antimicrobial susceptibilities, and what's called minimal inhibitory concentration, or MIC. By saying reflex test, this means that if they see bacterial growth in the first part, they'll automatically add on the susceptibility testing, and this means that they actually test with drops of different types of antibiotics to see which will be effective against what's growing out. The minimal inhibitory concentration, essentially a lower MIC value, means that it requires less drug to inhibit the bacterial growth. So if it has a very low MIC value, that's probably the antibiotic to choose because it will require a lower dosing or less time taking the medication to kill that bacteria. Negative result would mean that there's no growth or only normal flora of the mouth. Positive test here would indicate the growth of organisms associated with lower respiratory infection, and they'll report which ones. Cautions when using this type of test: not all causes of bacterial pneumonia are detected in this test. Only those in the list on the previous slide are detectable. Also, in vitro susceptibilities do not guarantee clinical response, so that there may be a difference between the growth in the lab of the bacteria in response to antibiotics and the response to antibiotics in the actual patient. So that wraps up this part. We'll talk about some other testing in the next video.